I'm going to take the prerogative as the moderator to just, while we're waiting to see what questions may be queuing up, to ask. We've talked a lot about training for the direct care workers and training orientation and in-service. I would like it if you would opine about how well prepared do you think the professional staff is now to conduct the type of training that you're suggesting? You can just use your mic in front of you.
I don't think they're trained at all. If we know the IOM report, Retooling for an Aging America, which came out in 2008, the problem with training around competencies and knowledge and skills in this area across the entire board, from physician to nurse to therapy to pharmacy to social work to front line, is pretty problematic. And we lack the faculty to also train. So it's a systemic lack of investment. I think it's worse in home care just because it's hard to get your hands around. And so it's probably even gotten less investment than anything else. But I think in general, we are not invested in this and in the folks who could do the training.
And I would echo Robin's comment. She pointed to what's happening in Washington State as a good example. I think whatever your views are on organized labor, it can be relatively controversial, particularly in this place. But they're a group that has stepped forward in a number of states to put together the infrastructure that's necessary to train people. I think, again, as I was saying, we need to influence the content of the training, but building that infrastructure, it's just not there, and it's a critical activity.
Thanks, Henry. And I see that we have our first question queued up.
Hi, thank you. I'm Catherine Bowles. I'm from the Visiting Nurse Service of New York Research Center and the University of Pennsylvania School of Nursing. I hate to change the subject because I think the workforce is such an important issue, but my question is for Tom. Tom, you gave us a terrific presentation about the great success of the VA system. And I know one of the reasons for that success is your ability to do telehealth successfully. And I wondered if you could describe for us what you think are the key things that make your telehealth program work when others across the nation struggle with making it cost and clinically effective.
I don't think I have the good answer to that. I would say I spent a summer, brought in somebody to help us take a look at our telehealth. I don't own telehealth. That's another. But we do try to integrate. About 15% of our veterans who are in home-based primary care are also on some form of home telehealth. And looking at the literature and what we do, it comes back to integration to me. Again, where when we contacted the teams and where it seemed to be working well, they were present with each other. Those who were running home telehealth were meeting regularly with, and they shared each other's frustrations and worked them out. And where it did not happen, then you had frustrations on the home telehealth folks. They say, we gather all this data, we send it over to the primary care providers, and they ignore it. And the primary care providers were saying, they're sending me all this data that says it looks fine for what happened over the last month, but what I really need is this. And they weren't getting together on what they need. So I think integration, kind of comes down to communication. But I think it can work very effectively. And it's kind of the relationships that we need to make sure are in place.
And how much do you think having one EHR across your entire system helps you?
Well, in emergency preparedness situations like Katrina, or veterans who find themselves traveling, and sometimes it's just one part of the state to another, I think it is tremendously valuable. I'm really disappointed that we've not solved that as a country.
Okay. Thank you.
Yes, sir.
Great, thank you. Mike Johnson, Bay Out of Home Healthcare. So an observation sort of leading into a question. So the discussion was terrific. The one thing that I didn't hear that I just want us to think about is if we look at getting people the right care at the right place, and in this case we think it's home, who's the right provider? And what I'm worried about is we have what I refer to as a little bit of an educational arms race going on. Every graduating physical therapist, soon to be occupational therapists, are clinically doctorally trained. Pharmacists are now all doctorally trained. And so are we overeducated to do some of the things we used to do? And is there somebody who can do it just as well for less? And I think the answer to that is yes, but we've got to sort of figure out how do we do that. And there are many things that the direct care worker, non-skilled, can do. And part of my concern is that if the family, getting the family engaged is a key piece of this, but if the family's perception is that the only person that can do this is a doctorally educated clinician, then all of a sudden they become disempowered, and all of a sudden, they don't feel like they can do it. And I think that divide is something that feels huge, but could be closed rather quickly. So just some food for thought, but it leads to a question based on the team-based concepts, Tom, that you talked about, and the comment about the home care worker not necessarily being included on the team or talked about on the team. So let's put them all on the team. Teams are both about leadership and followership. So what did you do to help your teams be successful? So the people who are used to being the leaders, physicians primarily, partly because of regulatory compliance issues, are sort of expected to lead these teams. Do they have the leadership competencies to know when to lead and when to follow? And for a direct care worker, do they feel competent enough when they should lead versus always follow? So I think those are some dynamics across interdisciplinary teams that are challenging, and would just like your thoughts and comments on how you handle that.
A couple of things on teams. So we do have interdisciplinary team training, and we make it a point, if you're going to have a successful interdisciplinary team, that means everybody on the team takes a leadership role. So you rotate that. Now we have VA staff. The home-based primary care is VA staff. VA relies on the community providers for homemaker home health aid services, for hospice. So I think we've got plenty of room to improve on that. How do we really embrace them as team members and the family caregivers? I think we're probably better at family caregivers because of our work involving them in care plans than homemaker home health aid. So I think there's a lesson there for us to learn.
I just came back from a program in Camden, actually, was talked about earlier today, because we have a home care housing program that's with the Camden Coalition in Camden, New Jersey, and it's a promotora model, and the truth is that the promotora is doing most of the frontline stuff, including managing the medications, getting the people involved in the chronic disease self-management programs, and working then with the rest of the team, with Jeff Brenner and the folks, the primary care docs, and all of the nurses and everybody else. So, and they're communicating with each other all of the time, and they don't necessarily need electronic communication. I mean, a lot of time, well, if you call a phone a communication, but they're often just talking together on the phone. This is not high tech at all. It is the communication with the entire staff, who's there most of the time and who is not there most of the time. So who can be that sort of liaison, and then how do they all work together around this? I mean, it's not rocket science. It's just you have to do it.
Just one quick addition. This is something that I've been, I think as others have been preaching for integrated care for a long time. One real challenge, though, I think, with the arms race to education, if you pay $60,000, $80,000 a year to get your advanced degree, and then you're asked to join a care team, how are you going to value your peers? I mean, the dynamic is really twisted here. And I think we have to be very thoughtful about how we bring people together. It's not something you can just pull off and say, oh yeah, we're going to invite the personal care worker in, I mean, these folks have been historically disadvantaged in many ways. They're coming from low-income neighborhoods that culturally are probably not even of the same orientation towards issues as the clinical teams. So you need to treat these folks with real care. They're tremendous value to you. And, when we wake up to realize this one day, I hope it's not too late, that we've disempowered them to such an extent that they no longer share their wisdom. So,
Thank you. Our next question?
George Dollar from Washington Hospital Center. Thank you for your kind words earlier. The VA is, in many ways, the testing ground for a lot of things that I think we could see in the future. One of the holes that we've been talking about all morning is that we just don't know very much about the ability and willingness of caregivers in the home, their integration into community services, what financial resources the family may be able to bring. So the first question is, do you have a mechanism for assessing that when you enroll someone in a home-based primary care program? And if not, if you turn to your panelists and ask, What are the questions that you would want to add to that assessment in order to better understand what's going on in the home?
So I think in our home-based primary care program, we do not require that you have a home caregiver. We do take care of people who live alone, but I guess I'd say our social workers and sometimes our nurses are part of that assessment. Exactly how they do that, I do not know, but we also have a really good track record with medical foster home, was finding someone in the community who says they want to be a caregiver, and we assess them in sort of their heart. How do you get to that? And it's a bit of a trick, but I really would like to hear from others how to assess the caregiver's will and ability.
Yeah, well, I can't speak to the caregiver as the term that you guys are using it, which is the home direct care worker. But the family caregivers, there have been a number of attempts at developing an assessment tool to actually look at how we can determine the ability and the willingness of the family caregiver to perform whatever the tasks are that are needed. There was an assessment conference that was held in San Francisco, maybe 2002 or something like that, where they came up with what the different basic criteria should be in an assessment tool. And there are some assessment tools that are out there that are being actually used. I mean, there was one that was developed, it was used in New Jersey, I know. And there was another one that was developed in Canada that's been used which the Canadian government uses to assess the family's ability and willingness to perform the tasks. And part of it is going to be, what are the tasks? And is this a little old lady who weighs, 75 pounds that she's going to be expected to lift and transfer her 180-pound husband? It's going to depend. Or is it the adult daughter? And is the adult daughter working? And does she have to continue working? And does she have kids that she's got to take care of as well? So is there more than one family member perhaps who can do this? Like Mr. Martinez today said he didn't have any other family members who would help out at all, even though he did mention that there was at least a sister in passing. But we don't know why she didn't want to participate. And so that's really, I think the family circumstance, the work, whether the caregiver's working, family caregiver's working, just their physical ability and what tasks. That's really the big issue. Are they going to be doing what we'd call pretty much medical care, basic beginning level medical care, maybe doing shots, administering insulin or something like that? Or are they just doing more personal care? So that's where.
Just real quickly, one I think that's important to add to your list is their willingness and ability to adopt the use of technology. While I agree, I don't think we're going to see robots. I think we're going to be surprised at how much technology is actually going to come into this space. The Googles of the world are planning this out, so hang on for the ride. And what we know about older adults and how they use technology is that they have real preconceptions about it being difficult and hard to use. And it's something that I think is kind of nuanced and is worthy of assessment.
I know we've gone over, and with your kind permission, we're going to just take one more question. We all know we have a hard stop at 10 minutes, so you have definitely a time for a bio break. So if we could just, because this lovely lady's been waiting in queue so long, so please, if we could just take the one last question.
Judy Stein, Center for Medicare Advocacy. I'm concerned that a lot of what's being said today is so important, and at the same time we're hearing these themes, the program Medicare that exists does have the availability of paying for technical equipment, paying for therapy, paying for home care, and I hope the people at CMS are listening, because instead of making sure that what is allowed now under the law is provided, it is inappropriately denying all those things. And I also wanted to ask Henry, with regard to direct care workers, we heard as we came in that I guess the fair pay law had been put off. Can't afford it. But what are the issues surrounding things like that to make sure that we don't have divides between the people who need these services and the people who provide the services? Very often, I think, well, anyway, so there are rights, and how do we make sure that we keep those rights together and move these issues forward?
Thanks for the question. And I think the rule, I think, lives to see another day. I think it's let's see what folds out over the next couple of days and learn exactly what action the administration took here. I think there was a legitimate need on the part of states to digest a very extraordinarily complex implementation here, tracking travel time, really looking at overtime, that how are they going to pay? The states just simply don't have the systems put in place yet. And so I'm hopeful that this isn't the end of something, and this is an answer to your question, Judy, that it's hard. And you really have to get in here and struggle with these values of, you know, in my community, it's like, oh, we're all about self-determination. The workers are just a tool, and please don't do that. These people, you depend on them. They're critical in our lives. So this will continue, hopefully. And the real struggle of who's important on the lower rungs of our societal ladder, I think they can't afford to pit themselves against each other.
Thank you very much.
To pit themselves against each other.
Thank you very much for this very robust discussion. You've been a great panel and you've been great participants. Please take your break, and then we are coming back. We're coming back at 3 o'clock.
I'm sorry, I'm going to look at our